Dr. Garima Rath, studying outcomes of pediatric cataract surgery with and without triamcinolone assisted vitrectomy.
Good afternoon, everyone. So today the topic I am going to present is studying outcomes of pediatric cataract surgery with and without triamcinolone assisted vitrectomy. This is my financial disclosure. So regarding pediatric cataract, when we talk about, it is one of the major causes of childhood blindness, and we can also call it as preventable childhood blindness. And so early diagnosis and timely treatment becomes very crucial for preventing irreversible visual impairment. And that too in the procedure, right eye power calculation is quite difficult and confusing due to the constant change in the size of eyeball. Also, post-operatively, children have a more robust inflammatory reaction than adults, and complications like posterior synecdoche, secondary membranes are very common, and that results in the blockage of visual axis. Talking about triamcinolone, it is a water-insoluble corticosteroid which is used extensively in various fields. It has an anti-angiogenic, vasoconstrictive and anti-permeability effect. When injected intracamerally, the granules of triamcinolone acetate are trapped on the surface of the vitreous body, rendering it clearly visible. The anti-inflammatory properties control the post-operative inflammation, which is the major concern in pediatric cataract surgery. So the primary objective was to study the outcomes of pediatric cataract surgery with and without triamcinolone assisted vitrectomy, and the secondary objective was to observe for any complication that is attributable to the use of triamcinolone acetonide itself. So it was a randomized experimental study comprising of study and control groups of 26 pediatric patients in each group, and was carried out for 21 months. The pediatric population that we included was from 0 to 6 years. Pre-op evaluation included history taking, slit lamp examination, B-scan and IR power calculation, and we did undercorrection for IR power, and all the surgery was done by a single surgeon. Same surgical steps, exception was that the triamcinolone was used only in study. So 0.05 ml of triamcinolone was injected below the IOL in first go, and the next dose was given into the anterior chamber to stain the residual vitreous strand. Follow-up was done on day 1, 1 week, 2 week, and then 3 months and at 6 months. During post-operative visits, the anterior chamber inflammation were looked for. So these were the results. Among the study group, the posterior synecdoche and inflammatory membrane was seen in 7 cases in control group, while it was seen in 18 cases in case of the control group. In case of study group, the inflammatory deposits were noted in 6 cases, while it was in 16 cases in case of control group. The next comes the posterior capsular opacification. Among the study group, only 2 cases had this complication, while it was seen in 10 cases in control group. This proportion of posterior capsular opacification was significantly higher in control group than the control group than the study group, with a p-value of 0.08. The resurgery was done in cases of 2 cases in study group, while 10 patients from control group underwent resurgery. This proportion was also statistically significant, with a p-value of 0.08. The post-op horizon IOP among the study group, only 5 patients had, while it was seen in 2 cases in case of control group. There was no significant association between post-operative IOP status and intraoperative triamcinolone, with a p-value of 0.223. Coming to discussion part, our study to a certain degree had results that were similarly reported by Allen et al. That posterior synecdoche was seen in 4 eyes in the study group and 5 eyes in the control group. Also, in the study by N. Dixit and Vasavada et al., posterior synecdoche was observed in 4 eyes in the study group and 21 eyes in the control group. There is no much evidence about resurgery in the articles except in the study by Praveen et al., where resurgery was performed in 1 case who had developed visually significant opacification. In our study of 52 cases, no case of endophthalmitis was reported, which is similar to the findings of Alam et al., Gupta R et al., Praveen et al., N. Dixit, Vasavada et al., and Kamalam, Solomon et al. The limitation of our study was that the study population was relatively small to reach the conclusion result that restrict the expansion of our findings to the general population. And also the study was mainly hospital based, it may not accurately reflect the general population. So these are my references.
How many surgeons operated on these patients?
I'm single surgeon only.
Single surgeon, because your reoperating rates are a little higher, no?
Was there some reason or some specific factors that you had considered for dividing into the case and control group, or it was randomized?
It was randomized. After taking consent from the patient and their, not patient, the guardians, we randomized the patients.
What is that? One complication you should have looked for.
The post-operative rise in IOP for.
Okay, that you have said. Anything else? Why do we use Triamcinolone?
Mainly to render the vitreous strands visible.
Correct. So what you should have looked for in the
residual vitreous strands.
Anybody had a vitreous not cleared completely.
Not properly cleared from the.
What IOL was used?
3-piece IOL was used.
3-piece?
3-piece
Huh?
No, ma'am.
No, you have dealt with pediatric population. What was the type of IOL used? Anything you think should have been used means IOL, the type of any preference in the pediatric population?
Was it uniformly same IOL, or was there a difference in the IOL? So which can attribute to the why there was so much of a repeat surgery?